Wow, getting quite a good group today. Well, I'll start. I actually have a couple of things up my sleeve today that I prepared to talk about, but I always want to start off with asking you guys if you have cases or something that you want to talk about that we can open up to the whole community here. So I'll open with that. Anybody? Good morning, Jethro. Anybody have anything that you want to bring to the table? Please. Usually I'm begging. At least today I've got some backup material. But it's always more fun to have some of your woes or successes to deal with.
We've been having some fun with hemoperfusion for NSAID toxicities. We've had about
What is hemoperfusion? What is that? I don't understand.
yeah, that's a great question. I've been meaning to look into figuring out what it actually is. We've been using carbon hemoperfusion as an adsorptive modality, extracorporeal adsorptive modality to remove and absorb the NSAID from the intravascular space in our patients that have ingested anywhere from 450 to 666 mg per kg of drugs like ibuprofen, a few naproxen overdose dogs as well. And everybody's done really well. I think I mentioned in the last session that we had one that still developed a mild AKI, but she recovered very well as well and is doing great.
I'd really like to understand. I actually 2 weekends ago now, this weekend coming up, so 2 weekends ago, I got called in. We had two ibuprofen dogs from the same household come in, and I just don't understand what attracts those darn dogs to that drug. I mean, that's got to be our biggest intoxication, and it's just a disaster.
Well, I think a lot of them have like that candy coating on the outside. It's a little bit
Yeah,
sweet to make it go down easier. I
but
wonder.
they'll chew open this dog. One of the two dogs that we did last weekend did well, and then the next day he vomited up pieces of the bottle. So they chew open an absolutely unopened bottle of those medications and go to town on them. It's just incredible, and it's good that we have a modality like hemoabsorption to deal with that, because the only other option was plasma exchange, and that's not as readily available throughout the country and probably more costly, certainly a lot more involved. So it's a great thing. I was just telling Andrew that there's a lot of new hemoabsorptive technology coming down the road, coming to a theater near you soon. They're now devices that remove cells. They're devices that remove, I'm forgetting, I got the folder right in front of me, but just all kinds of new technologies and new indications. That's the coolest thing, that there are new indications for these emerging technologies. It's cool.
And this was coming. Did you say you had attended the human apheresis conference? Is that where some of this was coming from?
ISPA, the International Society for Apheresis, and again, I think I mentioned at a meeting or sometime recently that I had been invited to a regional apheresis conference for a number of years, and for about the last 3 or 4 years, I've been talking mostly about hemoabsorption and hemoperfusion. And then I got told by the organizer, I said, when I presented a topic, they asked me for a topic, and I said, well, I'm going to talk about hemoabsorption or plasma absorption, I think was the topic. And they said, well, that's not apheresis. You can't pick another topic. That's not apheresis. And now you go to the apheresis conference, the International Apheresis Conference, and I just hit my mouse and everything went away. Let me get back to, here we go. And 50% of the meeting was about some kind of absorptive technology. So it's changing. Are you writing? What are you doing anyway?
I'm at a kids soccer camp.
Oh, I see.
It's summertime activities out here. It's a little bit later in the day out here. It's 11. But yeah, so I'm out here. So I apologize for there's family and music and kids yelling in the background and whistles, but
No,
had to join you guys anyway.
just heard you. So thanks for those comments, Jethro. Anybody else have a topic they want to present?
I If I could, while I'm still unmuted, I've got one more thing just to throw out there to everybody, just to let you
Okay.
know we were thinking about it. We have currently hospitalized, I think she's about a 4 month old female intact Labrador with suspected probable tetanus. And we met her 4 or 5 days ago now when she was just starting to be more affected by the tetanus, and she saw tetanus antitoxin. One of my residents and other colleagues dug up a couple of human case reports looking at therapeutic plasma exchange on the human side in people with tetanus. And so we did have a brief conversation with these folks about the potential utility, the uncertainty around it from an outcomes perspective. The human case studies saw probably 10 or more treatments of plasma exchange. I didn't get the exact plasma volumes that they exchange each treatment. And those guys were hospitalized for like months, and it didn't really show a great clinical improvement, but we did suggest to the owner that we could look at pursuing that as an uncertain option that could help. He declined, but I want to throw that out there in case anybody else had any reading experience or knowledge about that as a potential application of an extracorporeal modality.
What would you be removing? You think that you'd be removing the toxin?
Well, in the two different case reports, one talked about an immune complex removal as ongoing inflammatory slash, targets for their therapeutic plasma exchange in that patients. The other patients, they talked about circulating toxin. Yeah. And so how long after, you get the infection under control, is there still circulating toxin? So those were the two potential targets there, which is why plasma exchange seemed to be you know, the sledgehammer approach to just potentially get all of those. But it was uncertain. It was uncertain.
Hmm. Well, you need to keep your eyes and ears open for new indications because they're out there. And I think an untapped source of indications that in veterinary medicine we haven't tapped is a lot of neurologic diseases. That's one of the neurologists are some of the biggest referral groups to apheresis centers in human medicine, and I think there are corollary diseases that we see that that would be better therapy, or plasma exchangers. Some of our extracorporeal therapies would be better than conventional management at this point. And one was the polyradiculoneuritis, the coonhound paralysis. They think that I talked to our neurologist, and they say, well, we treat them, but a lot of those dogs stay in the hospital for weeks to months. And the ones that we've exchanged, boy, they're fixed within days. So you would get them out of the hospital much quicker and much better turnaround, and a lot less morbidity to having a recumbent dog sitting around in a ward. But there are all kinds of neurologic diseases that if the neurologist would just look at the human indications and say, oh, we got a disease that's very similar to that, and then we should start exploring it to see if some of our extracorporeal technology would be apropos. Well, thanks for
I came
those
this close to being able to treat a polyradiculoneuritis about 6 or 8 months ago, and the owner ultimately declined. But I realized the conversation is probably stronger coming from me direct to the client. It was through the neurology resident, and I think they may have overemphasized some of the potential risks associated, all the risks that we manage very well. So I now talk to clients directly rather than have it go through other folks, just so I can really give them the spiel and highlight how amazing it may be for cases exactly like that.
Yeah, we've done only a handful, 2 or 3, maybe just 2, but they responded very, very quickly, almost like a myasthenic. So that would be one to target. Sure, they can manage most of those conservatively, but at much more prolonged time frame. Anybody else have something that's burning? I had a couple of things that I wanted to get into, if you'll indulge me with that, because these are some issues that I dealt with very recently. Let me get my PowerPoint up here. We were called upon, and this is another indication that those of you that really are interested in extracorporeal therapies and want to do a really fun extracorporeal therapy that you know, that is growing and will grow bigger. And I should mention one of the other technologies for these cell collections, and also for some absorptive technologies, are to manage inflammatory diseases, chronic inflammatory diseases, things like IBD. So, you know, you might see those kinds of indications coming to the forefront, particularly with these adoptive inflammatory cells, like what I want to talk about just a little bit. And I want to talk about a complication that we had and how we manage it. But just first, for those of you who haven't dealt with or heard about leukocytopheresis, many of us that have a centrifugal system in our hospitals, this is an indication that is really growing quite a bit, and that's to collect adoptive T cells, cells, inflammatory or immune cells that have been targeted and programmed to go out and seek out specific epitopes in the body. And the typical one that we're all dealing with now is cancer, and primarily osteosarcoma, but there will be newer indications other than osteosarcomas. But this is about a 7-year-old dog that had a 4-limb osteosarcoma, and the procedure is that they do a leg amputation, biopsy the lesion to ensure that it's an osteo, or it could be any other cancer that you're planning to treat with this adoptive cell technology. And then you take a piece of the tissue and develop an intradermal vaccine for that cancer. And with these osteocytes, what happens when they become malignant, they start to express surface epitopes that aren't present in normal osteocytes. And so you got a very unique surface cellular signature on these cells that you can program the immune system to manage. Not with the vaccine. Obviously, we've dealt with vaccine for various cancers, but this takes it one step further. And then the animals, it used to be that they just went through the immune therapy. And if some of you were at the recent ACVIM forum, they've now adopted, they've modified their therapy. So they do go through one round, or they go through a series of carboplatin management. And that seems to even increase the efficacy of the immunotherapy. Then they're vaccinated with this intradermal vaccine that is targeted for these epitopes, of these unique epitopes of the cancer cells, and those are called antigen-specific epitopes. And then you generate a clone of adoptive T cells that have been programmed to respond to those unique epitopes. And then, so the animals are vaccinated with a series of about 4 injections over a period of about a month. And then at the end of the month, we come in with our apheresis technology and harvest those antigen-specific adoptive T cells.
Can I ask, sorry to interrupt. I don't know if it's just me on my phone. Are you sharing a PowerPoint? I'm not seeing any slides.
Oh,
somebody else?
Thank you for speaking up there, Jethro, because absolutely I'm not. But you know, now I've got to change.
I mean, your words were painting a beautiful picture. Of course,
I'm so glad. Well, I haven't changed. I've just been showing the one slide for the moment. So you know,
I knew it was going to get good here with lots of visuals. Thank you.
Let me share. and I'm going to share this screen. Okay, and then let me put my, and let me know, Jethro, if it shows up. Is it there?
Yep, looking good now.
Okay.
See your title page.
All right, so this is the dog. Again, this is a 7-year-old dog with a 4-leg amputation. And really a nice dog. We hardly had to sedate him for the catheter place. I guess it was a her for the catheter placement. But then what happens? Each of the cells in your flowing blood, they all weigh a little bit different. Some are a little bit heavier than others, just like the rest of us in the population. Some of us are nice and slim, and some of us, aren't quite so slim. And we take advantage of that because the specific gravity of different cells, the platelets, the T lymphocytes, the B lymphocytes, the stem cells, all have a little bit different specific weight. And so we can use that to layer them out, much like you would layer out the components of a crit tube to look at the hematocrit. But in this situation, we do a much softer spin of the cells in the centrifuge, and we can then spread out the entire buffy coat. And I'll show you a picture of that in a minute. And so this is the connector in the centrifuge, and this can be done either on the Amicus platform, and I'm going to talk to you about the Optia, because that's the one that we have and that I'm most familiar with. But you get an interface here. So this is plasma. Then the buffy coat will lie right on the top of the red cell interface. And in fact, on this one, this is the red cells way down here. And most of this range is actually the buffy coat that's been spread out. And you can see it here that you've got the plasma, then the buffy coat, and then there's a collection port that you vary by modifying this interface. And then you get just to the right spot, and you can collect the type of cells that you want to collect. So that's done on the Optium machine with a program that's called the collection preference. And so if we look at the layering of the blood from plasma to the platelets to the lymphocytes, and then down into the monocytes, and ultimately down into the red blood cells, you tell the machine by this arbitrary index that goes from high down to low to move the interface higher or move the interface lower until you start to collect the type of cells that you want to collect. And you get a visual display of where you're collecting on a screen on the machine, and these green dots sort of reflect the intensity of the color. So this image that's right here on the screen is derived from a camera that's looking directly at this collection port. And so the more cells that are being collected, or the type of cells that are being collected, you get a different intensity of grayscale that somewhat relates to the cell type or the region of this layering that the cells live that you want to collect. And if this color is too light, or you're not getting enough cells, then you tell the machine, well, dig a little deeper or come a little bit higher. And you do that through this collection preference. And all of this is regulated on the Optium machine by a software program called the AIM, Automatic Interface Management System. And we live by that. It used to be on the old machines that preceded the Optia. There was no AIM system, and you actually change the interface level by telling the machine what the patient's hematocrit was. And if you wanted to go a little bit deeper, you tell the machine that the hematocrit was a little bit higher. And if you wanted to go a little bit higher in the interface, you tell the machine that the hematocrit was a little bit lower. And you do this in very tiny steps. And with the new software, with the AIM software, they really did away with all of that, a lot of that guessing and that playing around. And it was a lot easier to use this collection preference system to easily collect the cells that you were most interested in doing. The other way that you would decide where you were in the buffy coat to get the cells that you want. This is the product line coming up from the centrifuge. Let me go back one step here. So this collection port then comes up. There's this line right here, and we'll be looking at, on the next slide, we'll be looking at this line as it comes out of the centrifuge. Oops, I went too many. And we'll look at this line as it comes out of the centrifuge, and then we usually tape that onto a card that sits on the top of the machine that has this color scale on it. And so, you know, if you want to collect platelets, you'd be way out here in the real light part. And if you wanted to collect T cells, usually the T cells live kind of in this color right here, and that's kind of shown here. So you would tell the AIM system or the collection preference system, you know, to go deeper. If you were collecting a product that looked like this, you would lower the collection preference to go a little bit lower, maybe much like this looks like here, where you go to this level down to this level. And then the color of the product changes. And the color of the product that you're collecting is due to the amount of red blood cell contamination. So if you're way out in the periphery of the buffy coat, then there are very few red cells there. And as you get deeper and deeper and deeper, the number of red cells that are contaminating the buffy coat become more, and that's what contributes to the color. And if you know that if you're collecting in this color range, that you're gonna be mostly collecting T lymphocytes. All right. This is just another image of that. And so again, this camera sits and looks at this portion of the collection, and depending on the number of cells and what kind of cells are there, you get these different grayscale patterns on the front of the machine. And here you can see the product coming up. So the product comes up from the bottom. It's pumped by this pump here. And now that product is coming up this line into the collection bag. And we're collecting pretty low, and we've got a beautiful color. We've got nice cells. This is probably an hematocrit of about 2 or 3%, this one. And we've got dark color here. And so all of that predicts that you're gonna be collecting something in the lymphocyte range. And the final collection product will usually look like this. I mean, this looks pretty red, but the hematocrit of this product is probably about 3%, maybe 3 or 4%. Well, we had this nice dog that we were collecting about a week and a half ago, and we turned the machine on, and the machine on says that the AIM has been disabled, or it's not there. And it may be, we've got an old machine, and when they came out to do the PM, they upgraded the software, and now our older machine is not compatible with the new software. And this has happened at Penn, and a lot of the programs that have these older Optia machines, which they now won't service anymore. And we put a big sign on the machine when they came out to service that do not change the software, because we heard from Penn that when they changed the software that it disabled the AIM. Well, now we've got the dog is in there, we've got the catheter in, and all of a sudden the machine says that there is no AIM. And then we had to decide, well, what are we gonna do? We're gonna, the dog wasn't on the machine yet. Do we just stop the procedure? Do we stop our plan, leave the catheter in, and send the dog to another program to get the collection? Or can we try to do this like it was done in the old days, where you would manually do these collections? So here's just a nice, so we decided that we were smart enough, you know, by golly, we can figure this out. After all, we've been doing this a long time. And we put the animal on the machine, and we tried to tell it different hematocrit settings, and all we got was this. nothing changed. So here's the red cell layer way down here, tiny, tiny, tiny little buffy coat layer. But the only thing that we're collecting at this point essentially was plasma, and then we'd change it the other direction, and nothing. The interface just wouldn't change by modulating or adjusting the hematocrit level. So we called technical support, and I'm go back one slide. No, we called technical support, and they said, "Oh yeah, you've got to do a trick. You've got to do a trick before you can get the machine so that it starts to recognize that you're doing this manually." And the little trick, which is not published in any of their reference material, and I tried to Google it and look for it anywhere that I could after the fact. And what you have to do is this button on the collection preference screen, so this tells you to go up or down. You have to sit there and tap and tap and tap and tap and tap on this button for about 25 to 50 times until that button turns gray. And when that button turns gray, then that sort of disables this whole collection preference system, which wasn't working anyway. And the camera wasn't working, the aim wasn't working, nothing was working until this got disabled, but nobody in the world except technical support knew how to disable that. And then once we got that disabled, we could put in a series of hematocrit readings until we got to this point. And I think this is not from this dog, but they wanted to get the interface right smack in the middle of the connector here. And they said, well, you're in the right spot now, just collect. And you know that you can't do any better adjustment than just to go in and again we went down. We told them that the hematocrit was 15% when it was really about 30, and then when we kept going up and up and up in the hematocrit and changing it until we got the interface right at this sort of 50% level. And she says, well, this is the best you can do, and just go ahead and collect there, and hopefully you'll get enough of the cells that you need. And finally, so we started like this before we figured out how to disable the collection preference thing. And then ultimately we got to this level. And at first when we did it, this whole interface across here was just all blood. And what we were collecting, and I'm not sure that's on the next slide or not, what we were collecting was mostly just bright red blood. And then I thought, well, let's go a little bit, let's see if we can do some subtle modifications. And by making one hematocrit percent change at a time, we were able to make an adjustment where we could then this is what it looked like at the beginning. So we're just collecting, mostly way deep down here. Well, this is probably, this is a picture from that collection as we're doing it. And you can see that the interface, the red cell interface is right here, and we're just collecting a lot of blood. And that's what was coming up on the collection line. And that's what we were collecting during that early phase of the treatment. Once we got the interface in the center here. And then like was done on the old Spectra machine, which was the predecessor to this, you adjust the interface by telling the machine that the hematocrit is a little bit different than what it really may be, and that moves the interface up and down. And so we made very tiny, subtle adjustments, one hematocrit point at a time, and then we finally got this interface where the machine thinks that the red blood cells are way down here. We got a nice buildup of the buffy coat, a really beautiful buildup of the buffy coat, and we're starting now to collect exactly at the color that we want to collect. And so the majority of this part of the collection now is going to be essentially T lymphocytes. And if we had this at the beginning of the treatment, then we would have had a really, really pure, essentially pure enrichment, not entirely pure, but the purity of the material of the product would have been a lot more lymphocytes than what we actually had in in the bag. And this is at the end of the collection, and you can see all the red blood cells have by gravity have just settled down here, but this is what we were collecting at first. And all of this beautiful material right here is our cellular collection, really at the color that we wanted to collect. And so my point of all of this discussion is, that if you're doing a cell collection on the Optia and all of a sudden your AIM doesn't work, don't give up. You can do this manually, as long as you know the tricks. And so call technical services right away to tell them that you're doing this collection and the AIM died, and now you need a fix. And what they'll tell you to fix is to push that collection preference button, until it turns gray, and then you have to just adjust it by adjusting the hematocrit. We actually ended up with a really great collection, though. So here is the animal's pre-treatment CBC. And this dog had 1,200 lymphocytes, and so that was a reasonable amount. Sometimes we get these animals and they've got 600 or 800 lymphocytes, and they're really hard to collect. But this animal had 1,200, and it was a big dog. So when you have a big dog and you have a big number of cells, and depending on how fast you're flowing, you can get the interface to build up like this. As long as but then it's a game between getting the speed fast enough that the cells build up at this dam. There's a little dam, right? You can probably see this little plastic step that's right here. And by increasing the speed of the centrifuge or the blood flow rate, you can get the cells to build up, but you have to also be cognizant that you're not collecting them too fast to deplete the layer that you're trying to collect. And so there are a lot of games that you have to play. But we actually ended up going from 1,200 lymphocytes count at the beginning, and we ended up with 27,000 in the bag. And it was contaminated a bit by, we ordinarily get a hematocrit that's in the range of about 3-4. Maybe sometimes you get a dark one, maybe 5% hematocrit. And this one, the whole collection had, because we had all those red cells at the beginning, was 16%. But we still got a 23 times enrichment of the lymphocyte population, which was the population that we needed for the procedure. And this isn't really one of our records, this 22 times. I think one time we got up to 27, 28 times enrichment on a collection, about a 3 blood volume collection. But this was a pretty good enrichment of the lymphocyte population without, we collected a lot of platelets because there was a lot of collection at the beginning when we weren't in the right spot. But really, other than the neutrophils that probably came, the neutrophils are below the lymphocytes. So when we were collecting really dark, we did collect a bunch of neutrophils, but these don't really bother the system. They'll centrifuge these out, and they'll get rid of all the red cells. But we ended up with what was going to be a disastrous day in a real problem for the client and the patient. Probably have to go to a different center to get collected. And these collections have to be done within a very narrow window of time. But we were able to figure out how to make the machine work in the absence of the AIM and actually end up with a good collection. I thought we were going to probably have a horrible collection, but it turned out to be quite good. So I wanted to stop there and see if there are any questions about that. And then I had one more topic real quickly that I wanted to bring to everybody's attention. Any questions about these site apheresis? These are really fun treatments to do. We really like doing them. Somebody grunt just to make sure that my speaker's working. Andrew, say something.
I was just going to come off mute. But I was going to say, we also do this procedure. We use the amicus. And if I'm honest, I don't know that I would have gone through the rigmarole that you did that day to try to figure this out. I think it speaks to your understanding of how these machines work and what we're trying to achieve here. But in general, when it goes well, I do really enjoy these cases. I think they're a lot of fun, and the pets do really well, and we've had very successful collections as well.
Yeah, this is a technology that's really picking up. I mean, a lot of centers that have centrifugal machines are really this is a other than plasma exchange, this opens up a whole new revenue stream for you. And again, they're fun to do. The patients, you can usually get the catheters in with just a little topical and maybe some sedation. Generally they're pretty well managed. At the end of the treatment, they had a lot of citrate and a lot of volume, and they really got to pee at the end of the treatment. So sometimes they get a little antsy at the end, but otherwise they're just a kick to do, and you feel really gratified, when you ended up collecting what you're trying to collect.
Agreed. We've actually started putting urinary catheters in a lot of them.
Yeah.
Because they end up being, by the time you're, in the unit and on the machine and you're finally done, it's probably 5 or 6 hours. And the last half hour, for the few that we haven't put catheters in, they start to really get quite antsy. So every male dog.
This dog did too. And we try to get them to pee on the table, and a lot of them just won't.
Right.
And we threatened to put catheters in them too, particularly if they're sedate enough, during the catheter placement, to just do that. But we haven't gone to that extent, but I think that's probably a reasonable idea. And I think the patients would be more comfortable with that.
Yeah, it just kind of takes one additional variable out of the equation. And most of them, I mean, some of the dogs will pee even right before you start, but some of them it's like, oh, it's raining outside, or they don't know the area and then they don't pee then, and then it's just even worse. So yeah,
And the other disadvantage is if they're moving around and you get a catheter alarm, that disrupts the interface, and then you have to wait till the interface reestablishes, and then you end up with a poor collection and a longer treatment. This dog was about 5 hours as well, but we actually ended up doing more blood volumes than usual because we knew that the first hour that we were fussing with the machine, that the collection was garbage. And we wanted to make sure, and we weren't really sure exactly what cells we were collecting. We did do an interim CBC, and we could tell that we were collecting lymphocytes where we were, but we wanted to make sure that they absolutely had enough material, for the. Oh, and I forgot to mention. So you send the product to Elias. And then they take these adoptive T cells, jazz them up with cytokines, and then make antigen-specific killer T cells. And then that's what they send back to the oncologist. And they infuse these killer T cells into the patient, and they go out through the body, try to recognize these epitopes, these cancer epitopes, and then they kill off those cells. And with the combined therapy of doing the chemotherapy plus the immunotherapy, they've really been able to extend the life expectancy of these dogs now much, much longer than what the traditional chemotherapy protocol is. I think the median time of the median life expectancy of these dogs went from about 300 days out to 400 days. And some of these dogs actually get cured, that they're out years without any cancer reoccurrence. So it's a promising therapy.
I have a question about that. I think it was either this ACVIM forum or the previous that they posted the abstract about the single carboplatin versus multiple carboplatin, and found that the single carboplatin actually had a better median survival time.
Then the adoptive?
No, in conjunction with.
Yeah.
So amputation and then single carboplatin administration and then the Elias protocol following there.
I think that was, they had a presentation like that in June at this forum.
Do you think it could be because when you do multiple carboplatin, you essentially continue to push out the apheresis and the collection, which then pushes out the reinfusion of the killer T cells, and so there's more time that they could still be, I don't know, I don't want to say exposed to the cancer cells in their body, but sort of.
Yeah, I don't know. But when I talked with them at their booth, I think they're using just the single carboplatin regimen.
Yeah,
And
I think
they're very excited about this. They think that it's really made a big improvement in their therapy. I wanted to go on to one more topic real quickly. And I think, Cedric, are you still on the call here? Monday, Dr. Dufay did a presentation on plasma absorption and told you about a technique that we had developed down in San Diego, but we've actually developed an easier and better technique for doing plasma absorption on the Prismax platform, Prismax or Prismaflex platform, and I wanted to sort of introduce that to here to people that haven't done it, because we've abandoned the other way. It was just too complicated and didn't work very well, and the newer way just works phenomenally. What we're talking about, this is if you're doing let's say a plasma exchange for some antibody for whatever, you know, this is the target range of what we are typically doing, somewhere between 1 and maybe 1.5, 1.6 plasma volumes of exchange. That gets, you know, that removes something. Let's say you're looking at a removal of some toxin or removal of some substance, whatever it is, you get about 70–80% removal there. But to get to way down to essentially removing all of that substance, it takes probably 5 plasma volumes of treatment in order to do that. Well, there's no way that we're going to deliver 5 plasma volumes of treatment on a single treatment, because as you see from this curve that looks at the change in the fractional change in the substance with more and more plasma volumes exchanged, that this part of the curve gets pretty inefficient. And so we usually stop here. It's pretty linear at this point, wait a day or two, come back and do another one of these. But you know, if you were dealing with some kind of an intoxication, let's say you're dealing with Amanita, or you're dealing with something where you need to get rid of all of it, you might want in the first treatment to get down to this level. And typically with plasma exchange, we're going to have 2 or 3 days. It's going to take 2 or 3 days, maybe even 4 days to get down to this level, depending on your schedule. And so we would want to treat in a single session what you might ordinarily be required to do in 2 or 3 sessions with just straight plasma exchange. And one of the options then would be to, if you're going to do your plasma exchange, do that and then put on an absorptive device and do plasma absorption and do another 3 or 4 or 5 plasma volumes of exchange using absorption. And in that situation, then the patient's own plasma becomes the replacement plasma for the treatment, and you don't have to use donor plasma for that treatment. Or maybe you just eliminate the apheresis part of it. Or I don't want to say apheresis, because we know hemabsorption is now apheresis, but rather than do the plasma exchange, maybe you know you want to do plasma absorption from the beginning, and maybe you're using an absorptive device that's toxic to the cells, and so you can't expose the cells to the sorbent material. Well, you just separate the substance you're trying to remove is in the plasma. Then you just separate the cells from the plasma, and then run the plasma through the sorbent to remove whatever you're trying to remove out of the plasma. And then you could do that either on a centrifugal machine. And here's just an example where this was obviously an IMHA patient. We're treating it with plasma exchange because we want to get rid of the antibodies. But this dog also had a bilirubin concentration that was, you know, that was 60, and he was really neurologic for that bilirubin. The plasma exchange, and this was a 1.5 plasma volume exchange, that only reduced the bilirubin concentration by about 40%. and the dog was still had a bilirubin concentration at the end of the treatment that would have been potentially neurotoxic. And so at the end of the plasma exchange that we did for the antibody elimination, then we put on a carbon sorbent and did another 3 plasma volumes of treatment to remove the bilirubin. And so in the first treatment, in the first single treatment, instead of getting a 40% reduction in bilirubin, we actually got an 80% reduction in bilirubin by doing the adjunctive plasma absorption. So this was probably on the Optia. It's really easy to do this on the Optia or on the Amicus machine. This is kind of what the setup looks like on the Optia. The blood comes in, it goes down into the centrifuge, and then the plasma comes up from the centrifuge, just like I showed you a few minutes ago. And then ordinarily, then that plasma, the waste plasma that you would do, like when we were doing the plasma exchange for the antibodies, just goes up into a remove bag. Here's the remove bag that gets thrown away at the end of the treatment. After the plasma exchange, then we switch, we clamp off the line to the bag, and we add in the carbon device on a secondary line that's available on the circuit, where if these bags only hold 5 liters, and so if you needed to remove more plasma, you can attach another bag to this line. But we use that bag then to provide plasma to the inlet to the absorber, and then the outlet of the absorber goes to a little kind of a transition bag. So we've got the animals contaminated plasma coming into the device. The output of the plasma that's coming out of the device then goes up into this small blood bag, and then the return plasma comes out of this bag back to the patient. So we're using the patient's own purified plasma to serve as the replacement solution. So that's a pretty easy setup to do, and we use this little interim bag because the remove pump and the return pumps don't always work at the same flow rates, and so you need a little bit of a reservoir of plasma in there so that the bag doesn't suck air. On the Optia, I mean on the Prismax, and what we thought, well, geez, how would we do this on the Prismax? We can put a plasma separator on here. We can get the plasma out, run that through our sorbent. But the problem on the Prismax is that you've got to satisfy the requirement that every drop of fluid that comes out of the plasma into the plasma waste bag has to be matched by exactly the same amount of volume that comes out of the replace bag. And so you've got that constraint that these two bags have to be matched, and you can't just do the plasma separation without having some kind of a replacement that's going to be going back to the patient. And what we first devised is that we would just run the plasma out, we'd put it in the waste bag, and then when we got a certain amount of volume in the waste bag, now this is purified, this would be absorptive purified plasma, we would just switch that bag over to the replace bag, put the replace bag back on the collection and collect. But this is a lot of fuss, and you end up with a lot of diminishing returns because you get to the point where you really can't get this bag full enough to put over here to get a good treatment. And we just, when we tried and did this, it worked, but it just was cumbersome. It didn't work very well. A lot of complications, and then we're trying to figure out how to make this better. And for one of our Renal Week lab sessions, we kind of put our heads together and tried to figure out how can we do this without switching these bags, and how can we trick the machine. And what you're always trying to do on these treatments is, how can I trick the machine so that it will do what I want to do and not be upset. So the issue is that we have to satisfy this requirement that whatever comes out of the from the plasma separator has to be matched by a volume that comes out of the replacement bag, so that those two bags are exactly balanced in their in the volumes that they're receiving and the volumes that they're removing. And it turns out that an easy trick to do, I mean, you have to make a couple of modifications to the system here. And the first modification is you have to change the position of the bloodline. And so on the bigger sets, you've got this lure connection in the bloodline that comes out of the top of the plasma separator into the air separator here, to waiting for the replacement plasma to join it. Well, we can disconnect that line. That's a lure line. We can put a stopcock in there, and then instead of the blood coming directly into this air separator here, we can have it come in kind of secondarily. So now it's going to go through the stopcock. It's going to meet the sorbent purified plasma, and then at the stopcock here, rather than in this chamber, and then the blood out of the plasma separator and the new replacement plasma is then going to flow into this chamber. So that's an easy fix to do, and you can do that very aseptically. Better to do I think if you're going to do this, it's better when you open the setup when it's entirely sterile, that you wear sterile gloves and masks and cap and go in and make all of these connections very aseptically when it's still in the packaging, so that you don't have to make this maneuver later on in the treatment. The other modification you have to do is you have to reroute the replacement line. And so the replacement line from your replacement bag, which sits here, comes up through this pump, I guess, and then goes directly into this chamber, at this bottom pump. And this is something that you also have to do aseptically, and because this is directly into the patient's blood. And there are two ways of doing this. One, if you have a line, one of these line clamps, which we have on the Opti machine, or you get one from your hematology unit, you can just heat seal the replacement line here. Now remember that all the replacement solution to the dog is gonna occur up here in this stopcock that you put in, so now we've sealed that line. Everything is aseptic, and so now we have the sealed line. Then we put a stopcock on the replacement line, and then we put a line on the other end of the stopcock that directs that replacement fluid directly into the collection bag. So for every drop of fluid that comes out of the patient's plasma is replaced by a drop of fluid that comes from the replacement bag directly. And then you don't have to put plasma, and you can just put water in this bag, and the machine won't care. It will just continue. To pump fluid out of this bag to match the amount of weight or fluid that would come into this bag. Technically, that would come into this bag. And I guess it works the other way, that it pumps fluid out of this bag into this bag, and so the amount that's removed here shows up here, and then the machine is happy. The other way you can do this, if you wanted to do the plasma exchange and the plasma absorption, you hadn't programmed that at the beginning, you could aseptically put a stopcock in here, and this is where I would recommend. If you're in the middle of the treatment, then I think you're obligated to just heat seal this line. But if you anticipate that you're going to do plasma absorption, again, when everything is in the sterile packaging that it comes in, you just cut this line, and then you can swedge on a male lure into that line that fits very, very nicely. And here we've got a male connector that swedges on the replacement line. And then so you do your and then you would take and put the replace line onto the stopcock. When you're doing the plasma exchange, you would just close this connection so that the replacement solution goes into its normal route. When you're finished with the plasma exchange, you want to do plasma absorption, you just turn off that line, open up this line, so that now the replacement solution goes directly into the collection bag. And I think maybe that's shown here. So here's the whole circuit. We've got Martian plasma coming out of the plasma separator. The Martian plasma and this was just using this lure connection that's already built in the line. And then we take the waste line that would normally go into the bag. We just put that on a stopcock, and then that goes into the sorbent. You got green coming in, you got clear coming out, and now this clear plasma, your replacement plasma, is going to meet the red blood cells coming out of the plasma separator and going into the air separator here. And then the replacement solution is going to come up here. It's going to go through this stopcock, which now is turned off to the replacement line that goes into the air the deaeration chamber, and that line is going to be directly routed to the collection bag. And if you do this, the machine will run for hours and hours and hours and hours and hours and never complain. And then you don't need any fancy replacement solutions. You could just put colored water in here or anything, saline or whatever you want, because we've satisfied the weight changes on these scales. So I just wanted to present that as an option to the other system that Cedric talked about in Academy on Monday. And with that, I'm finished with everything I wanted to talk about today. No comments.
Your speaker still works.
Good. But this is easy to do. And it just works really, really well. And again, this adjunctive plasma absorption is a feature that I think is going to come more and more into fashion over the next couple of years. And there are going to be sorbent materials that are not going to be compatible with the cells, and then you'll have to do plasma absorption rather than hemoperfusion. And that was the case at the ISFA meeting, that a lot of the sorbents that they had to be done on plasma. So they were using the same, they were all using centrifugal machines to collect their plasma. But you can do this as well easily on a Prismax or a Prismaflex, just like you would plasma exchange. Any comments or any questions or anything else?
Have you looked at the capacity for like vet rescue versus like the carbon-based, the amylogic, as far as like ability to adsorb the bilirubin? And have you noticed any differences between the two?
Yeah, I didn't show that. For bilirubin, Cedric and I did a study maybe 4 or 5 years ago, looking at vet rescue and carbon. And for bilirubin, both of them do a very, very good job with removing bilirubin. I don't think there are a lot of other head-to-head comparisons at this point. But the vet rescue will, I don't know what the total capacity is. In the study we did, we were using a 100 mil carbon column versus one of their bigger vet rescues. And so all I can say is they both removed bilirubin efficiently. What the capacity, the comparative capacity of the two devices, I don't know that.
What I would mention too is that at the time we were using a carbon formulation called Bingo, which I
Yes.
think is not on the market anymore. And now Dublin has probably more binding capacity than Bingo had in the past.
Yeah.
So it would be fair to probably do that study again with similar capacity devices and try some of a carbon formulation like Dublin or Echo that might actually perform better than what we had at the time.
Yeah, that's a good point, Cedric. Thanks for that.
Great, thank you.
Mhm. All right, well, we're at the hour, and appreciate you all listening to my ranting. But hopefully, you know, if anybody runs into the problem with the AIM, that now you have some understanding of how you can get it corrected. And if you're going to do plasma absorption on the Prismax platform, you have to be you have to maintain strict sterility, and so again you have to put these connectors in under aseptic conditions, but it works really well. And with that, I bid you all a great weekend. See you in a couple of weeks.
Thanks, Larry. Have a great weekend.
Thanks so much.
Okay.
Take care.
Thank you, sir.
Yeah.